Happy Holi. So we request some more time, like another 2 minutes, we'll be starting the. Let's start this masterclass. Healthcare is a complex structure, and delivery system. The delivery of a healthcare system involves different stakeholders. Quality can be a common paradigm to address to lead all the stakeholders in the healthcare. So do we understand that is it a quality which makes the foundation, or quality is noted for the superstructure of a hospital? Let's understand today in our masterclass. Before going ahead, I would like to introduce my college, that's Institute of Health Management Research, Bangalore. Next slide, Varghese. Our parent organization, IIHMR Society, was started in the year 1984, and Bangalore campus was started in the year 2004. Our course, that's a PG, Post-Graduation Diploma in Management, was approved by AICT in the year 2010, and our society was granted with the university status in the year 2013. In the year 2017, which marks a landmark for our institute, we have been introduced a new specialization, that is Healthcare Information Technology Management at IIHMR Bangalore. We received MBA equivalence by Association of Indian University in the year 2018, and in the year 2020, we have started with a new specialization, Pharmaceutical Management, adding a feather to our crown. And we have also extended our batch size from 120 from the year 2020. Next slide, Varghese. IIHMR Bangalore has 4 verticals: academics, research and publications, training, and consultancy. Coming to academics, we have a flagship program of 2 years. It's a 2-year full-time course which offers a specialization in hospital management, health management, health IT management, pharmaceutical management. As I said earlier, the seat offerings for this course is 120. We have excellent placement records, and we are proud to say that in the last year batch was placed within 2 months of announcement of our placements. Coming to our research and publications, we do take up evaluation, formative, implementation research, social assessments for national and international organizations, government and non-governmental organizations too. Currently, we are handling a project with UNICEF and ICMR, which is an implementing project which is implemented in the state of Karnataka. Our thrust area is RMNCH+, life course health, non-communicable diseases, health communications, and digital health. We do take up the research project in urban, rural, and tribal area. Learning and development. The Learning and Development Center is one of the core strengths of IIHMR Bangalore. We do take up management development programs, faculty development program, executive development programs, certificate programs, student engagement programs, webinar series, and we are proud to say that we are equipped with in-person, virtual, or hybrid mode of programs. IIHMR Bangalore has an organization, and the faculties in IIHMR Bangalore do take up consultancy services, and the thrust area would be NABH, quality management, growth and strategy, and project impact assessments. Next slide, Varghese. We have also been recognized through our awards. One is we have been ranked as a top hospital management college in the year 2017-2018 by Higher Education Review magazine. Received National Award for Excellence in Education in the category Educational Institute with the Best Academic and Industry Interface by World Education Congress Mumbai in the year 2020. We have been ranked 11, Best BE School rank 11 and 10 by the Week and the Outlook in Bangalore in the year 2021. Best Business School for India for the year 2021 by the Knowledge Review magazine. So these are our awards or recognitions. We are also accredited. Next slide, Varghese. We have also our flagship program, the postgraduate program in hospital and healthcare management, is approved by AICTE, that's All India Council of Technical Education, and also accredited by the National Board of Accreditations, that's NBA. Our program also received an MBA equivalence by the Association of Indian Universities, and we have registered under National Institutional Ranking Framework, that is NIRF. Next slide, Varghese. We have been empaneled with the state and central level government organizations. Under Jal Jeevan Mission, we act as a key resource center for training the L3 level. Under NHSRC, we are partnered for the implementation research for health system strengthening. We are also recognized as a consultant organization for NABH by the National Accreditation Board of Education and Training, that's NABET, under QCI. We have also empaneled with National Health Authority for facility assessment of healthcare entities for state health authorities under PMJY. We do take up monitoring and evaluation projects under Karnataka Evolution Authority. These are few empanelments of IIHMR Bangalore. Next slide, Varghese. And coming to our main, the Learning and Development Center, which is you're all part of it. We do offer, we do take up certain services, learning and development services, which will enhance and aims to improve the management practices and skills in the industry of stakeholders. The amalgamation of the technology, healthcare, and business, we develop unique career accelerating programs for working professionals, doctors, allied healthcare professionals, students, aspirants who are willing to take up in healthcare industry. We are, as I said earlier, we are equipped with in-person, virtual, and hybrid programs. Next slide, Varghese. Some key programs which IIHMR Bangalore has taken up and been successfully running through the years is certificate course in integrated digital intensive care management, which is a unique, and we have started with the second cohort. We also have a certificate course in nutrition and health with partnership with University of Mysore. We also started with the second cohort of this. Under quality, we have a certificate course in quality assurance and accreditations in healthcare, for which Karnataka Medical Council have given 6 credit hours, and it's been successfully running and started this year. We also have executive program in digital hospital management and executive program in hospital management, which would start in the month of May. So our training partners are across the globe, and as you can see in the slide, we have partnered with University of Mysore, Maastricht University, and HX Central, VJU Global University, Cloud Physician, and Burjil Hospital and RxTS. Next slide, Varghese. Coming to our current program, the Masterclass, Foundation versus Superstructure Quality Management in Hospitals. We have two panel members. Next slide, Varghese. Dr. Usha Manjunath, our professor and director, IIHMR Bangalore. With over 20 years of experience in management faculty, she has a unique experience with allied health and disability, communication, entrepreneurship, general and health system management, and research and academics. She is a dynamic leader with an interest in behavioral science management and entrepreneurship, academics, teaching, consultancy, research projects, training and capacity building, entrepreneurship, and social and developmental work. Besides this, she has also published a book on total quality services in healthcare in the year 2012, and also been awarded with Bharata Ratna Indira Gandhi Gold Medal Award. Welcome to you, ma'am. Our next main resource person would be Dr. Uma Nambiar. Uma Nambiar, a neurosurgeon, healthcare administrator, and international healthcare consultant with over 30 years of experience in healthcare industry. She has also completed her MBBS MS from Armed Forces Medical College, Pune, MCH in neurosurgery from Sri Chaitra Tirunal Institute of Medical Sciences and Technology, and MBA from University of Delhi. Her specialities are in strategic consultancy, healthcare policies, commissioning new hospital, process engineering in the existing hospital, process standardization, and quality in healthcare and healthcare IT. Her illustrated career has served in many capacities, including CEO of the Global Hospitals, Regional Director, Fortis Hospital, and CEO SL Raheja Hospital, and Chief of Neurosurgeon at Rajiv Gandhi Cancer Institute of Delhi, among others. Welcome to you, ma'am, and it's a pleasure to hear to you today. Thank you, Vargas. Thank you so much, ma'am. Now over to Usha, ma'am, for the welcome address.
Yeah, good evening, everyone. Good evening again, Dr. Uma, and welcome. It's always a pleasure to have you with us. And happy Holi to everyone. And, we were just talking before, because it's a, major day, we were wondering, on a festival, how people are going to attend. And we're very happy that you've all joined for this program. And just to kind of, just take 2 minutes to say about Dr. Uma. She has been associated with us, IIHMR from very long, almost 2 decades of our association, and, various capacities. As you saw, for a doctor and a neurosurgeon, that too, to the kinds of things that she has done and she has been associated with is, amazing. Her experience in quality, as well as now the digital health and association with establishing various health systems or within hospital systems and in India as well as abroad, and has been a very she brings with her a very rich experience. And as much as wanting to invite all of you and welcoming and talking about quality, I thought, this is a good opportunity for me to learn something new, as we looked at, the title itself. So I'm as curious as all of you are to kind of learn on this. And in terms of the format, I think Dr. Uma said that the whole session, she has some interactive ones. I would like and, welcome each one of you to participate actively. I will be taking some questions and others from the chat. If required, I may, kind of intervene gently for Dr. Uma to answer that, especially if it's very relevant at that point. And, in terms of, if there is a requirement for people to speak up, and maybe Dr. Uma will inform that during her presentation on the interactions. So, clarify your doubts. We have always been looking at quality. My own research and PhD was in quality in healthcare. And way back in 2005, in India at least, there were less people working and doing research. So I was looking at total quality service framework, and we have come a long way in these 15 to 16 years. With NABH kind of making it more explicit, establishing a lot stronger base for people to start off with. But at the same time, hospitals and, should we go for NABH or NABH? Why NABH? We're already doing quality. Or, some places may be like, okay, we have NABH, get NABH, but, back to business in the way that we had done. That doesn't mean to say that quality has not been a focus for the hospitals. Our healthcare professionals are recognized across the world as very good and excellent in their skills and competencies in delivery. But as hospital takes many shapes, or the delivery of healthcare takes many shapes. It's not just hospital now, maybe it's home healthcare, it is telemedicine, it could be, single and daycare hospitals. So the formats have been changing very rapidly. And now with, the digital aspects, now we have a lot more changes which have come by. So, the quality systems are, have to be established, whether it is JCI or, NABH. And patient safety and the provider safety, as well as customer-centric, provisioning and personalized care, all this have come in, together. And so therefore our quality and the way we look at it have to be very strongly viewed with, a different kind of angle, but at the same time, put systems that is workable, which will help us understand, the outcomes, how we are really going to do it. So I think, it's like I always say, it's an exciting time. We were in India was in 80s, was on an expansion mode for the hospitals. Now we are in the expansion mode for digital aspects of hospitals and healthcare. So I think, in terms of how we have done, it also showed us during COVID, the things that were possible for us, the things that were difficult for not only us in India, but across the world, the health systems. So I think making quality at the core of it is everybody's interest. And so I'm here to enjoy and learn from Dr. Uma's session as much as all of you are. So once again, welcome. And
thank you.
Dr. Uma, thank you. It's always a pleasure to
Thank you so much. Thank you so much. Yeah, and I will start sharing my screen. Are you guys able to see it?
Yes, ma'am.
Yeah, and I'm going to just do the full screen and see whether, just tell me whether it's moving to the next slide. Can you see the movement? Did it move?
Not yet. It is not full screen yet.
Oh, so what happens is it comes full screen here. It doesn't come full screen there. But I'm going to now try and see whether.
Yeah.
Is it moving?
Yes.
Yes.
All right. So there's a new thing I learned in Zoom, what you do. You put it on the reading view, not on the full screen view.
Okay. All right.
So sometimes it's, so yeah, so anyway, I'm very excited to be here, let me tell you, and this is something which is so close to my heart, the whole issue of quality in healthcare and digitization and the new changes that are happening. And like Dr. Usha said, that we are very fortunate to be living in these times where suddenly so much is happening in healthcare. And all said and done, despite the fact that there were a lot of things that were negative about COVID, but there was also a lot of learning which happened because of COVID. And I would say that that learning, which would have otherwise taken 10, 15 years, it sort of got telescoped into in 2 years. And therefore, I think we are in for a lot of surprises and a lot of good surprises, provided we are aware and we are open to the reality. So why are we discussing this today? We've now known, I think I've been part of this quality journey and NABH since 2004-5, when it just started. And we are still talking about what is quality for a hospital. What does it mean? So I want to take you through 2 cases, okay? And I want you to raise hands and tell me, maybe 1 or 2 people can tell me what is relevant. So the first case, both cases are 150-bed multi-speciality hospital. So in the first case, a year after inception, they got NABH entry-level accreditation. They applied for final level after 6 months and they couldn't clear the audit. Whereas in the second case, 150-bed multi-speciality hospital decided to go straight for a final accreditation, did not do the entry level, and initially thought they will do entry level, but while they were doing it, they were so confident that they can go for the final that they cleared the final audit within a year of starting the hospital. So I just want somebody to make a guess as to what went wrong with the first case, or what did the second team do right? Are there anybody who wants to raise hands? And Deepa, you can see who's raising hands and you can ask them. Random, there's no problem. Otherwise, just pick somebody if they're not raising hands.
Sure, ma'am.
Yeah.
Yeah.
Anyone?
Ma'am, I think Dr. Abhishek has messaged in the group, in the chat, and said that follow up the protocol not properly. So the first...
Abhishek can speak.
Yeah, Abhishek, you can open up your mic and speak, Abhishek. Abhishek. Or Ankit Gaur, who has messaged in chat, can open up the mic. Yeah. Yes, Shekhar, we can hear you.
There's a disturbance in Shekhar's mic.
Yeah.
Anybody who wants to say, unmute and say. Yes.
Good evening, madam. Because of they are not completed as the facilities for NABH accreditation, they are failed to approach, I think.
No, they did entry level and they were successful. So what went wrong between the entry level and the final?
Because NABH need a lot of, they will seek infrastructure, equipment, and staff, as well as the function hours of that hospital, as well as the quality providing, and there also see the number of cases visiting that hospital. These all are mandatory for NABA certification.
Okay, yeah. Anybody else?
I think in case 2, they are completed, they fulfill all these requirements.
Yes. Okay. Anybody else?
Maybe in case 2, maybe in case 2, they would have laid the infrastructure foundation and adopted the standards while they were starting. Compared to the case 1, where they would have started and then they realized that we'd have to first see where we stand. So let's go for entry level and analyze, evaluate our position. So maybe the preparation or the baseline was better with case 2. So they had the confidence of directly going for a final accreditation and they cleared.
Yes, that's right. So, as you rightly said, yeah, anybody?
I think Dr. Ruben wanted to have written in the chat. Dr. Ruben, can you open up your mic and talk? Because he has written in the chat the sustainability part. So, and Dr. Radha, you can open up the mic and talk, Dr. Radha.
Good evening, Madam. Dr. Radha here. I think leadership also matters in this. Basically, I mean, like leadership and the team motivation also. I think probably in the second, probably a better leader who could get the things done. That's what I feel.
Yes. So you see, a couple of things have come out in the last, in these discussions that we are doing. As Radha just said, okay, one is about able leadership. More importantly, also good teamwork. Then about a good foundation having been laid, as in like when they were starting, they had it in their mind, the complete picture as to what they want to go for. They were very clear, whereas the first hospital probably was not so clear. And like Shekhar had said that, the completeness of the project in terms of the infrastructure, the facilities, and the protocols that they were following was probably not complete. So yes, all these reasons are right. So in the first case, you see the reason for which they would have applied is also could be the wrong reason, right? They went because they wanted empanelment with CGHS and all that, that little 20% extra on consultation, and they were not really bothered about the quality per se. See, you have to be very important. The first thing you need to decide is why are you doing what are you doing? So if you decide that you want to go for NAB accreditation, what is your purpose? So if your purpose is really quality and patient safety, then you would be the case to that hospital where the entire team believes in it and does it. Whereas in the first case, perhaps the belief was not strong enough. The reason why they were doing was the wrong reason. And it was like a chalta hai attitude. Chalo, we have done this. Now we've done entry level. Maybe we will get the final. Let's apply and try. So it was not that they probably did not focus too much on it. And perhaps they didn't have a good team. Okay. So what I wanted to highlight was there's never a one reason, right? There are multiple reasons for why we don't achieve quality in our hospitals at a certain level. It has to do with our processes, it has to do with our design, it has to do with our thinking, and it has to do with the team. So let's go forward. So this is what is commonly they would have both done. So I actually wanted to show this to you earlier. They would have both done the same, but one made it and one didn't. See, because these are the standard steps. So they all go through this, right? So what is the purpose of healthcare system? Let's have somebody answer this. Why do we run hospitals or the healthcare system, not hospitals, the healthcare system? Anyone?
Again, the question for the participants. So
Yes.
what is the purpose of healthcare system? Dr. Radha?
Madam, basically, provision of health is a basic necessity. So provision of health for everybody is important.
Right.
Okay. Akanksha has opened up the mic. Akanksha Srivatsava.
Ma'am, to provide a better health care to the diseased person in a proper way, like the way we provide a proper customer care wherever we go, in a mall, in a shopping complex, the same way we should provide the patient care to the patient, not only from the doctor, but also from the entry staff, from the front desk, from the nurses, from the pharmacists, from everyone.
Okay. Hasiba Qureshi.
Hello, good evening, ma'am.
Yeah.
Ma'am, I personally believe the purpose of having a hospital or any kind of healthcare services in our locality, the first of all is to restore and maintain the health of the people around. Second, to provide the training and efficient training to the staffs for providing the best quality of healthcare services to the patients, and also for the research purpose. This I believe that these are the work should be done in a hospital, apart
Right.
from imparting healthcare services, research and training.
Right. So very good inputs from all of you. So I have just bundled them into two buckets. One is what falls under treatment, and the other that falls under prevention of illness or wellness. So which means management of disease and management of wellness. Both should be done in any healthcare ecosystem. And it's not just hospital. When I'm saying it's the entire ecosystem. Yeah. So these are the expectations from a healthcare delivery mechanism. That is that we will provide good quality healthcare at low cost, and it will be available to everyone. And this is a global requirement. So I use this slide in everything related to healthcare, because healthcare, the expectation of the public from any healthcare organization or person is the same. Now this, you all already know the definition of quality, so I don't have to, really repeat it. I've just put it here because since we're discussing quality, this is just for the sake of completion, but I would like to discuss more often on what happens on the ground, okay? So the degree to which healthcare services for individuals and population increase the likelihood of the desired health outcomes and are consistent with current professional knowledge. Okay, so all these various aspects will become clear as we go along. So this is what we talk about our hospital as, in our routine day-to-day conversation. A small hospital or a big hospital or an enterprise class hospital. This is what we were discussing, that it has multiple services, clinical and non-clinical. And when we talk of quality, we talk of quality in the clinical as well as the non-clinical aspect of the healthcare. But look at the real picture, the elements of the entire ecosystem and how they are all interrelated. So if we address quality in just the prescriptive health space, and we do not address it in the population health space or in the wellness space, then it is useless. It doesn't serve the entire purpose, because what is the purpose of quality? The entire well-being, in the entire patient's journey or in the entire life of the patient, every time they have an encounter which is to do with illness or for that matter, wellness related or preventive health checkup related stuff, they expect quality delivery. Okay. And similarly in population health, because if you are looking at a group of people, then unless they all have standard quality of healthcare, you will not be able to do anything further to that population for the well-being or enhancing the well-being or augmenting the healthcare needs or providing the relevant healthcare needs of that population. So therefore, it is not enough to look at what we saw here. This is a very narrow tunnel vision approach for quality of healthcare. Because when we start thinking, we say, okay, patient comes from the front office and then gets discharged, and we just look at this space. That is what this space is. This is a very narrow space in any individual's lifetime. So if we look at our lifetimes, how many times do we really go to the hospital and have this encounter? Most of us never do that. And some of us who do that maybe once or twice in our lifetime. And most often it's more for needs like delivering a baby or something like that. So not even a proper, serious illness. So this is a very, very narrow space. The entire space that we are addressing is this. This is a cradle to death kind of situation for a citizen. So right from the time that we are born, all that happens in our life, which is the first thing that happens in our life, is a wellness intervention. What is it? It's a vaccination. Okay, so from there onwards to any episode that we may have of hospitalization or OP encounters, and then collectively the data that goes to the government and the policymakers and how the epidemiologists work with that data, and we have our policies made for us or the national programs for health made on that basis. So when we look at the limited space, which is what we all do when we manage hospitals, we talk about patient rights, we talk about patient safety, we talk about clinical support. Now, public health is where it comes to population health. Leadership and governance. You remember in the case study, it came about that leadership is extremely important. Similarly, governance, like what is happening in the NDHM today in our country, and we'll talk about it when we discuss a little bit about the IIHMR Bharat mission. Operational management of the hospitals, and like Shekhar had mentioned about facilities and infrastructure, creating the appropriate facilities and infrastructure for the hospital. Now, these are the buckets in which we measure the various standards that we have. So I am not enumerating any standards because all of you know everything. So this is just so that we know, okay, look at these buckets. Now, there are some buckets which are not coming here, which I will discuss later as to what we should include more in addition to this to go beyond this. So whenever we look at any of these buckets, what do? This is how we prepare a sheet for the parameter that we want to measure. All the various aspects that we want to measure about a particular benchmark. We create multiple benchmarks in the different buckets that we spoke about. We create benchmarks based on discussions within our teams. Of course, first is take the benchmarks which are given by the NABH or JCI or ISQA or any other quality standards. Then discuss with your team. What is given by a third party is not all the time relevant to your hospital or inside your hospital or your system. So discuss with your team and then make your benchmarks. So modify and make them. Okay. Now, for all these benchmarks, what do you need? You need data. Now, quality management, or in fact, for that matter, hospital management is nothing but data management. Now, we talked about hospitals. Now, what is conventional practice about? So if we really look at what is treatment or wellness all about, it is about a physician or a nurse or a technician examining a patient, collecting a set of data, whether writing down on a piece of paper or assimilating it or mentally in my framework. Then you analyze it in your own mind. The physician does the analysis. And what is that analysis based on? It's based on the knowledge that I have from the books that I've read. It's based on the clinical discussions that I've had in my lifetime. It's also based on the experience that I have seen similar patients. It's also based on the articles that I read and what I've seen in the rest of the world that people have done. And if there is something which I find that I need to read again, I'll go and do some reference reading. And that's what gives me the knowledge to analyze that set of data which I have and prescribe the treatment for that particular patient. So healthcare or treatment or wellness. So healthcare management or managing the health of an individual or treating an individual is nothing but scientific data analysis and interpretation. So that's basically data science in its most evolved form. And what are the various inputs today if you digitize? Okay, besides what the clinicians has already written down in the EMR, you have data from the HIS. Now, what is the relevant data that comes from the HIS for the patients? It is their demographic profile, it's their age, their social history, so on and so forth. From the equipments, various lab data, radiological data, that's interface, from various IoT devices, from various apps. So you get a plethora of information. You have so much data that gets collected. And that gets organized and analyzed today by computers. And then you have the AI algorithms that run on them. So AI algorithms are nothing but a copy of what your brain does, but it does it faster on a larger number of data. But to do that, it needs a rules engine or an algorithm to be worked on and to be developed by some of the programmers. For us, nature has done it. We don't need an AI rules engine to be written at the back. When we read something, we already know how to assimilate the information and where to recall it and when to use it. Whereas in computers, it will not recall or it will not use that information if the appropriate rules engine is not made. So therefore, you need to develop that program to an extent that it can match our brain. Okay, so the capacity of pattern recognition that our brain has, it can be multiplied many-fold when we use computers. And that's the advantage of using these AI algorithms to help predictive care and personalized care and in the care continuum thereafter. So what AI does is something which our brain anyway does, it augments it more. So why am I bringing this in the topic of quality? Quality management is nothing but monitoring parameters and benchmarks. For all those parameters, you need data. I would say the journey for quality on healthcare has just gotten a lot easier by this automation. No longer has the nurse or the quality manager or the quality executive to go with a piece of paper and go to the ICU and say, this patient has fever, this patient was ventilated on such and such a day, create those handwritten notes, then come back and write the Excel sheets. And then at the end of the month are trying to, really work day and night to create a dashboard out of all that and try to figure out whether there is a relationship or not. This job just got a far lot easier. And it also, therefore, we also need to say that the quality, therefore, can be expected to be far better. You can get your alerts much faster. You can intervene much faster. You don't have to wait to see the dashboard at the end of the month. So when we say that, okay, we want to provide safe patient care, effective patient care, patient-centered care, timely and efficient care, all these what we expect in quality healthcare, by digitization, these just jumped up to the next orbit. This is what is the future. This is what is going to happen. And now let's take a step back. When we saw in this slide, what's the first thing that you do to treat a patient? You collect data. which means the basis for anything that we do in a hospital is collection of data. The patient comes to the hospital, you identify the patient, data collection. Why do we need to do? So that the wrong patient doesn't get, to avoid wrong surgery on a patient, or the wrong medication on a patient, so wrong patient selection. So it starts from there. So everything is about set of data. Now we go here. Now in this, we realize that when we computerize and we standardize the data collection, how easy does this become? Okay. Now, something that I wanted to talk about when we discussed the first and the two cases is that besides these factors of, when we say that, okay, we manage data more rationally and more scientifically, and we make the quality journey easier, we cannot overlook the fact that sometimes, or in fact, most often, teamwork is something that is very imperceptible otherwise. But given a critical mass of people, if they work as a team, the results are phenomenal. So what happens in good teamwork is that people who cannot perform because they have certain limitations, those get overcome by somebody else who compensates. So it's a little bit like, I don't know how many of you know about neuronal plasticity. So in the brain, if a certain part stops working, the neighboring neurons take over the function of that. You've seen patients of stroke recover. This is how they recover. You've seen patients who have certain injuries, they recover after having a deficit. They recover because the neighbors who realize that this guy cannot do his job well, they will take over. So that's brain teamwork inside of the neurons in the brain. Now, we as in teams, we work like that. We also need to realize that who's the person who's being treated, who's the center of our healthcare universe. The center of the universe in healthcare is the patient. We often forget to take the patient's view. So it's important to take the patient's feedback and to act on them and to understand where, because quality is also about what is being perceived by the patient. It's not only what we are monitoring. So we need to ensure that we also include patients. Now, there is something called no-do gaps. Anyone who knows what it is? You've heard of this before? So yeah, I'll tell you. So go back to case 1 and case 2. Maybe they all had similar teams, similar knowledge, everything was there. But one team could do very well and the other could not. So we may know everything, but in a certain situation, because of various other factors, we could not do. So it is not the lack of knowledge, but it is the lack of ability to transform your knowledge into action. And these gaps are there in some organizations because of various other factors. Okay, sometimes you may not be able to pinpoint what the factors are, but things just don't move. And that's the no-do gap that we see quite often in various organizations who, for all other factors, they would be same. Okay, so I wanted to also talk to you about patient advocates. I usually call them patient ambassadors, but I came across this term called patient advocate. So I'll tell you what this is. And way back in 2006-07, I realized that, some patients or their relatives, they come back to you with such strong negative feedbacks about all the things that are not happening right in the hospital. So what I started to do was I used to call them once they went home about a month later when they came for review, and I'd say, come and have tea with my HODs or team leaders or the people against whom they had written most complaints. So we would all get together and they would narrate their experience and they would also give their suggestions on what they were expecting. Now, this was something which gave the staff a lot of motivation to improve patient care, because they realized that there's a human being at the other end. most often we become so mechanical in our day-to-day work that we forget that we are dealing with an emotional being who's in the bed. And we start to look at them as disease, we start to look at them as bed numbers, we start to look at them as a painful patient, we start to look at them as a person who will always, create a problem or will be always complaining, all of that stuff. But when you talk to them after they come back, you realize that all that your staff was doing or saying or not being careful about what people are listening, the patients have an enhanced ability to perceive everything. They hear before you even start speaking. You murmur and they hear very loud. So you realize that you have to be very, very careful. And this helped the staff to work with much more empathy with the patients and created a much happier situation in the interaction that we had in our wards. And although there may not be a benchmark for it, what you measure, there may not be a parameter, as the patient was happy, 9 out of 10, may not be. But these are imperceptible factors or human factors, which I say human factors in the staff and human factors in the patients, that we must look at, which we may not be able to measure. And this can only happen if we have a culture which is deep rooted in the organization. It doesn't happen in 1 or 2 Excel sheets. It is not part of a dashboard. But this is our day-to-day behavior. And day-to-day behavior is something which is almost like it needs to be really into your genetic code. So this is learned behavior. Okay. Sometimes it is there, this behavior is there in us, it just needs to come out because we need to provide the right atmosphere. These are all part of what you deliver as quality of healthcare. Okay, so the trends for the future, you spoke about IIHMR Bharat, and I had to, speak a slide or two here. See, we mentioned about citizen or a patient being the center of the universe. Now that's the new paradigm. Okay, we have been traditionally used to a doctor-centric healthcare system. Doctor says, patients listen. Doctor says, hospital does. Doctor has to buy this equipment, it will be done. So it was always doctor at the helm of affairs. Things have changed and things are changing rapidly. Now, we already discussed what is healthcare. It is data science. It's management of data science. Whose data is it? It belongs to the patient. It is the patient's illness, patient's data. So who should control it? Patient. And that's exactly what's happening here. Now, patient controls who sees his data, where the data is linked up, what he wants to get from the insurance system, which doctor he wants to see, which hospital he wants to see, where does he want to get admitted. And when you are traveling, you travel so much, wherever you are, in the manner in which you seek healthcare, you can decide. So this is the power to the patient. And this is the future that we have to adopt or adapt to, both. So when the patient will come in future, it's almost like, I don't know if have any of you read the book, that Doctor, Your Patient Will See You Now. Okay, so there's a book, okay? It's called Doctor, the Patient Will See You Now. And that's truly the depiction of what we are going through, what are we transitioning into, and we are in the middle of it. This right now, this is the cusp phase where some of the people have already started to behave like this, and the others are yet to jump on the bandwagon. But give and take a few years, it will be the reality. So it will no longer be the doctor scheduling the patients, but the patients scheduling which doctor they will see and when. Okay, that's how it will be. And when we really look at this, we would have arrived at a true cultural transformation. So what is expected of us right now as hospital managers, hospital leaders, and you all are going to be in various levels of managing your hospitals, you have to remember two things. One is that the person that you have to be focused on is a human being as flesh and blood and emotions as you are. Second, it is about the data that belongs to that patient that you need to make sure that it is authentically, rationally, and correctly managed. And that's your responsibility. So whether it is about collecting that data, whether it is about transferring that data, whether it is about securely, ensuring security of that data, that is our domain and our responsibility. That is where we fit in. We are custodians of that data for that patient. Patient is the owner of the data. We are custodians as far as they are in our system. Then it goes to the portal which is anyway they have access to. But while they are with us, we need to make sure that the data is secure, because as we are, going more and more digital, the chances of data security breach are very high. And those things are our responsibility. And right now, JCI, NABH, they don't address issues of data security, issues of data integrity. We have to take the lead. We need to understand that we are not to just go by the indicators that are mentioned in NABH book saying, okay, tick checklist 1, 2, 3, 4, 5. I've done my 34, I've done my 74, I've done the numbers, I'm done with it, and I'm NABH accredited. That doesn't, that's not even the beginning of the story. The story is about the safe patient care. And when it comes to safe patient care, since patient care is about data management, it is about security of the data. It's about management of the data, which none of these standards address. They address in superficiality. They do not give you the tools to address that. So we have to learn that, we have to understand, and we need to get into the next phase of healthcare quality and understand that since this is the basic premise is data. So it's like saying that if I need to create a human being, I need to have the DNA strands with the right, code. So if I need to treat a patient, I need to have data structured in the right sequence. Okay. Unless that's available to me, I can't go forward. I can do nothing to the illness or wellness of the whole story. So that is what I want all of us to remember, that it is nice to make Excel sheets. It's nice to know that we have ticked the boxes, but do not forget that behind those boxes, way below, your boxes can be ticked right each and every time if your basic infrastructure is correct. If you have laid the foundation for data collection, which is appropriate. So structured data collection, which is scientific and rational and right for the management of the patient. That is our responsibility as managers of the hospital, to provide that framework. Okay, so whether we are talking about accreditation or you talk about clinical performance, patient safety performance, or as I mentioned about perception by the patient. So, I usually run a department in my hospitals called the patient experience management. Okay, and I really do this patient experience quite seriously. And these things have to be, looked at over time. It's not a one-time thing. So for all these to be done right, as I mentioned, that if it's not part of your building block, scientific data collection is not part of your building block, you cannot achieve any of these aims that you set out to do. You can check the boxes 1 time, 2 times, but not the 3rd time. So each time you might get the first accreditation like what we saw in case 1, but you won't go further with it. Okay, so let's now try and help these people. So case 1, what we discussed, what is it that they should have done to get their final accreditation? Let's have a few views on this. Who's going to help them?
So participants, again, the question for you. Now, about 150-bed hospital, 1 year since inception, NABH entry level has been applied for And final level, could not clear. Now, after listening to ma'am, what is your thoughts again for the case 1? You can open up the mic and speak. Akanksha, can you unmute yourself and talk?
Ma'am, there should be less error in the data collection of the patient, as ma'am has told us previously. And what I feel being a doctor, that we should treat the patient with empathy. And as ma'am has said, that there should be a quality check, not from from the doctor side, but also from the entire staff. There should be a teamwork. Someone should take the initiative for the proper teamwork, and there should be a good and proper coordination between the medical staff.
Okay.
Ilayaveni, your thoughts?
Hello? Yeah. Yes, ma'am. So I feel the first point that ma'am mentioned, that to believe in, what we want to achieve. I think that is something which is very crucial. So I would say that, the collective belief that this is what we want to achieve, and keep patient as the center of that belief. I think that would be one, step which can help them in achieving quality.
Thanks, Dr. Ilayaveni. Dr. Kunmun? Yeah.
Yeah. Good evening, ma'am. Ma'am, there has to be a quality for the first time and quality every time. So it's not just about the quality for the first time. We have to implement the quality throughout the phase. So there has to be a culture of quality, as you said. We have to. There has to be leadership, governance, teamwork, human performance has to be together. As we said, teamwork. The total efforts of all the members to be taken into account. And as you said about the no-do gaps, we know everything, but we do not implement. So that thing has to be taken into action. And a proper data collection, there has to be a reliable, complete and analyzable data. And also the confidentiality of the data should be there. And one thing has to be kept in mind, that the person with whom we are treating, that empathy part has to be there. Thank you, ma'am.
Thank you.
Dr. Radha, do you want to add upon a few points?
No, madam. I think nothing specific. She has covered everything.
Yeah.
Okay.
So yes, very good inputs by all of you. So they had, like what we discussed before, probably the reason for doing the entry level was not entirely correct. So they need to understand why they're doing. So it is not NABH for the sake of NABH, because that's what it was in the beginning. It should be NABH for real quality of healthcare. And then they have to, implement all the right steps to look at quality at a larger level, with the entire team involved in it, with proper data collection and right patient care, and focus on quality and not focus on the label of NABH. You have to focus on quality because you want to do it. It has to come from inside. It has to be, in the culture of the organization. It has to be in the heart of every individual that works. So yes. So for case 2, now they are already, they have already done their NABH certification. And we know that many organizations, when they go for reaccreditation, some of them slip back a notch or two. Sometimes they, some of them, of course, they continue to do well. So what would your advice be to them? You can say about a few things that you've seen, what happens to hospitals after they've got their accreditation. They're all so euphoric, and then immediately budget gets cut, the quality team size reduces, because reaccreditation only after 1.5 years, So then saving money starts, manpower costs will be cut, and many things will be, not managed properly. And then just 3 months before you're again going for your survey, everything back again, quality team, more infection control nurses, all that stuff. So what would your advice be to them?
Madam, rather here, I would like to answer. I think sustainability is very, very important. And it should be an integral part of the team involved, every hospital. basically, and it should be maintained. That much I can say.
Yeah. So we have understood that if you don't have, good quality at the core of the organization, you cannot develop. So sustainability of the quality initiatives, as I said, is not for quality for the sake of quality. It is quality for the sake of the wellness of the organization. So for the growth of the organization. So organizations need to look at all quality initiatives as an investment rather than as cost. So if they have to put 2 people to do a particular job in the quality department, then they need to put those 2 people. It's not that ab NABH mil gaya, so now it's like, okay, now these 2 people can be, asked to leave. We will recruit somebody after 1 year. No, it's not like that. And this is something that happens in organizations. And why I need you to emphasize this here is some of you are senior leaders in organizations. So you need to make sure that when there is a question from the board that your manpower cost is high, the easiest manpower to cut is these departments. So don't fall prey to that temptation to save your manpower cost and, all these little costs trying to add up to your EBITDA. No, because it will hit you in the long run in a very negative way. So that's one thing. And if you are a junior member of the team, if you are in the quality department, you are the chief of quality, hold on to your guns. Don't listen to, you have to really make your case for a strong quality department. Sometimes it really requires a lot of courage. You can't be seen as a department that is like just there. No. So it's an important department. It's a department which is an integrator of all the departments. And you need to be friends of all rather than be looked upon as, oh, this is like, somebody's come to spy what we are not doing correct. That culture should not be developed in the organization. So it's necessary to advise the second hospital to make sure that they continue to pursue the quality journey and continue to do it for the right reasons. Okay, so I've got 3 cases here. These are the cases for the future. So you have a 150-bed hospital, okay, all this. So it has its own hospital information system, and the quality team collects data on Excel sheets and makes reports for analytic dashboard. So I want a few comments on this hospital. One is, of course, a comment on as to how difficult it is, what is the so the parameters on which I will want you to answer this is how reliable is the quality or the parameters that the report, or do you think that they're able to achieve the desired quality of the hospital or the desired standards of patient safety? And you can give me an example or 2 on where things could go wrong and seriously go wrong. Similarly, in the second, and so it is in the third. So I want you to compare these 3 organizations in terms of patient safety, where and how patient safety can be compromised in these. So the first one has its own hospital information system. It does not have any other IT system. The nurses, the technicians, the quality coordinators, infection control nurses, they all go around to the bedsides or to the equipment. They note down the data on a piece of paper, create Excel sheets, and then report. Second, the hospital has a hospital information system and an EMR, which means the doctors also write on a digital software, on a software platform. But this HIS and EMR are from 2 different companies, and they don't speak to each other. Okay, the HIS collects its own data, EMR collects its own data. So somebody has to physically collect and collate the data from the people. The third one has the HIS, the EMR, the human resource information management system, ERPs, equipment interfacing, and interoperability. And this is patient portal. Sorry, this is a spelling mistake. It's patient portal. So they have the case, so the third case, the hospital has all. So the difference between HIS and EMR, some of you will know, but just for clarity, HIS is a hospital information system that collects administrative data, mostly about registration and billing, okay, and scheduling. and EMR collects hardcore medical data, which is about patients' symptomatology, treatment, medication, and nurse notes, doctor notes, so on and so forth. Okay, so your comments on compromise of patient safety in these three situations, and which one do you prefer?
So participant, there are 3 case scenarios. Your thoughts on these case scenarios?
And
And
why I've said, why I put these is almost all hospitals. I mean, now with NDHM and IIHMR Bharat and all that, all hospitals will be going digital. So all the hospitals where you will be working will fall in these 3 categories. And you will be working in these hospitals to know how to really get best patient safety and quality out of the situation that you have, and what are the shortcomings and what is it that you want to improve going forward. So what would be your end journey? If you are in a hospital which is like case 1, what is it that you should insist that the administration has to do and spend money on over the next 5 years to get to maybe where case 3 is, you know, just giving an example. So I needed you to think through this situation and say how this compromises patients' safety for you.
Yeah, Dr. Bhavinder, I think you should speak. You have put the answer there.
Hello, ma'am. Dr. Bhavin here. Ma'am, whereas a case 1, there are a different person who are collecting the data. So it might be possible that the one person ICN is collecting the data is a difficult, whereas the quality person collect the data, or whereas some manager collecting data. So this becomes a chaos in a single person data. So I would suggest that a single system is available for all the stakeholder, whether it's ICN, a quality person, or a manager. So after the whatever the last decision we're taking for the patient, so it is a more beneficial to the patient. So my suggestion is that a single system available for all over the hospital. So all the stakeholder have the exact data and the same data.
Yeah, so but the first hospital does not have that single system. The single system is only available in case 3.
Yeah, so I would suggest that hospital has to put some money in that particular HIS system.
Yeah. So
So
can you
over the
give an
years.
example of errors that can happen in serious errors that can happen in a hospital like the case 1? It is because of differences in the personal variations of data collection. Yes.
It is like maybe we can see in the radiological department, like if a ICN is getting the culture report of a patient as a some what we say a culture report comes positive. So ICN knows the report of the day of the 17th of the May. I'm just giving the example. But when the quality person see, so second time she or he see the culture report of 19th. So that particular date, that incidence, what we say, directly affect to the patient. So then doctor or maybe ICN or the quality person cannot decide which one we have to take. So there will overall it will affect to the patient, because on that culture report basis, doctor will be prescribed the antibiotic, or whether we have to go for higher antibiotic or lower de-escalation or escalation of the antibiotic.
Yes.
That will
And
directly
there are
harm.
instances, yeah, and there are instances where serious patients have died because we have
ma'am.
made a delay in, you know, when there is only one antibiotic to where there is a sensitivity of an organism and patient is very, very sick or immune compromised. And that 1 day delay can kill a patient, you know, it happens in hospitals. Yes.
Yeah, ma'am. Same, it is happen. We can take to the like in a high risk medication, the same thing we can take that.
Exactly. Yes.
Yeah.
So high
because
risk
there are
medication that happen.
medication management is a more important in the all the hospital or in the quality management system.
Yes. So medication errors. So you can miss medication errors because when physically a person is going and collecting data, it is not possible to go and see on every patient. You know, and if there is some wrong medication that has been given, sometimes it may not come to our notice for a very long time, or it may never come to our notice. Whereas if it is completely automated, then your medication errors can be prevented completely. At least
Yeah.
the administrative, the prescription and administrative can be prevented, so easily. Yes. So what is the problem between in case 2?
Ma'am, what I have get for the case 2, that when the 3 different companies we have using the system, so it may be possible that we can converting the data. Like one company is.
So in effect, they are as good as case 1 when it comes to data collection and collation.
Yeah.
So technically, बोलने के लिए तो they've got an EMR.
हाँ.
They are digital.
But वो convert नहीं हो रहा data, तो
but
उसका कोई meaning नहीं है.
they are as good as case 1 only.
Yes, ma'am.
Physically, the nurses or the technicians or the quality coordinator has to go to different systems and take out printouts or take the soft copies, put it on Excel sheets and collate themselves. So it takes a lot of time and you don't have it available right away.
So what in my way, ma'am, if we compare case 1 and 2, so for me, the case 1 is the more better than case 2, because in case 2, we have to club and combine the 2 systems, then put the data. Whereas in the case 1, we have a single system. But yeah, there is a.
And in case 2, and in case 2, we have a false sense of complacence, thinking we are digital, and thinking we have more security, whereas actually we don't have.
Yes, ma'am.
Okay, so we are complacent. We are not giving that much of. In case 1, we know we have a limitation.
Yeah.
In case 2, we don't know our entire limitation. We feel that we have digitized now, so we are okay. Okay, so what is interoperability? It's not related to this session, but it is important because it is important to get good data for your monitoring. What is interoperability?
From the understanding of data between 2 systems, and in a sense that they data in one system, there should be a means of translating that and the other system receiving it, and all of this should make some meaning. So there should be some meaningful data coming out of
meaningful data communication, bilateral data communication between different softwares. That's what it is, correct. So, okay, so that is the end of the discussion today. So now the floor is open to you guys to discuss what you feel you want to discuss.
Yeah, thank you, Dr. Uma, and very insightful, very in a simple fashion put. So I will just, Hasiba Qureshi has raised her hand. Go ahead, Dr. Hasiba.
Hello, ma'am. Ma'am, I need to have your ideas on introduction of remote monitoring program in India and in a hospital. Will introducing this program can help out to patients, and what is your opinion on that?
Okay. So, yes, this is the way forward, right? Remote healthcare or telemedicine is the future, okay, which is digital doorstep, okay. The patient will be, see, right now we are limited to, when we say patient, it is after patient has entered the portals of the hospital. Now healthcare is reaching where the patient is, which is to their homes. Okay, so our data collection starts from there. Our interaction with the patient starts from there. It's a remote interaction, but it starts from there. And going forward, the remote interaction will be far more than the actual event-based interactions. Right now, we get admitted for many things which don't require hospitalization, which can be managed at home or it can be managed near the homes. So that's, so is that what you wanted to ask? Or is there something?
Now, what's the future of telemedicine or like remote monitoring program in India?
Future of telemedicine is that the telemedicine is here to stay. It might have taken a downward curve now immediately post COVID because everybody wants to go out and everybody wants to go back to the hospital. But going forward, you will find that most hospitals now make a department of telemedicine, right? Telemedicine now, because it can be paid for, and it can be paid for even by the insurance companies, it'll become one of the preferred modes for OP consult. It certainly will become a preferred mode for follow-up consultation. And whenever you are going from one town to the other, or you are traveling, this is the only way you can connect with your doctor, because you would like to keep your doctor. You know, you don't have to, like if I'm getting treated by a doctor in Delhi, I don't have to go every year for follow-up. I can just connect with him on telemedicine and go only when it is required. So this is definitely the future. How soon will we reach that critical mass? It is difficult to say, but it will happen. You see, during pandemic, we were like almost 100% telemedicine consult for 3 months, isn't it? So it will happen. So people have realized that, okay, so what will also happen? So telemedicine is not just simple telephonic conversation or an audio video conversation between a doctor and a patient. It is far more than that. It has now many devices that are connected to augment your telemedicine consult. So let me give you an example of digital stethoscope. Now we are all, used to listening to the heartbeats of the patient and diagnosing what the patient has. So it's like, really, if you see the status symbol of a doctor is what? That stethoscope around our neck, isn't it? But digital stethoscope, which has correctly programmed AI algorithms at the back, can listen to. So if I put the digital steth on my chest here, you can hear that in Bangalore through these Wi-Fi connectivity of my remote telemedicine consult or the telecardiology system that you are connected to. And this digital steth is so much more powerful that it can hear what my human ear could not hear. And it certainly can interpret far more than what between my ear, since I couldn't hear, I could not interpret in my brain also the sounds. Whereas this one can interpret far more and give you much better diagnosis, because it has in its AI program, it has millions of heartbeats that are stored. I have heard maybe 1,000 heartbeats, okay, in 1 year. This computer has got so many. So the digital step is going to become more and more refined and more easily available. Now also it's available, it's not so expensive either. Similarly, there are a lot of the tele-diagnosis of diabetic retinopathy, different stages. It's a pattern recognition. It tells you which stage of diabetic retinopathy the patient could be having. One of the commonest causes of blindness in diabetics, isn't it? So in an early stage, it can pick up and you can intervene. So you don't have to go to a remote rural area. A doctor sitting in Chennai, in Arvindai, or Shankar Nethralaya can see the diabetic retinopathy in the villages. And these are things which are happening today. What will happen in future? You will have teleportation of patient, and now you will have, haptic sensors are being developed for touch. So you can wear that glove and you can, that sensor, if the patient can attach, and you will be able to feel that patient. Okay. You already have tele ultrasound monitoring of a fetal heart sound and the uterine artery sound and the algorithms that tell you that the patients, that there is fetal distress happening. Okay. I mean, it's just a belt. And the, a woman who's at high risk pregnancy, she's given that belt to wear so that the doctor sitting in Bangalore is able to tell that this fetus is now going to be distressed. So it is time to transfer this to another hospital, to take the mother to the higher hospital, and thereby prevent neonatal mortality. So for all these high risk pregnancies in rural areas, where otherwise it's only when the lady is in labor, you realize, oh, things are not all right. And now before she even reaches a hospital, she would have lost the baby on the route or in the ambulance, or the mother would have died. So these interventions are already happening in the tele space. Teleradiology, you already know, it's like it's taken over the world, isn't it? So we are in it for the long haul. So I always say that, in your brick and mortar structure, what is your basic healthcare organization? Your primary healthcare center, isn't it? Your basic. In your digital ecosystem, what is your basic? Telemedicine. Starts from home, from Asha worker noting down on an iPad. Okay, that's where it starts.
All right. So that is so much on, almost a science fiction.
Thank you so much,
line,
ma'am,
right?
for wonderful.
It's not science fiction, it's happening now.
Yes, no, like in terms of teleportation, haptic
Teleportation is already in, it's happening without the touch. Okay.
Okay.
Now you all know metaverse is happening, right?
Yes. Yes.
Yeah. So metaverse in healthcare is
All
going to be teleporting patients.
Yes. So I just want one, often asked question, which is there. I think, it's from Sheikh. If hospital accredited to JCI and or NABH, it means the hospital is providing quality and safe services to all patients at what level? Or is accreditation, this has been an ongoing question, on everybody's mind, and most people kind of, look at ISO or JCI or whichever ones. So is accreditation for brand to make money? So your comment.
So NABH entry level is accreditation to make money. Okay, I can confidently say this. It is to get empanelment by all the organizations and all that, so that you can get that 20% more on the consults. It does not really, if the organization is not serious, then it doesn't add anything to the quality. But if the organization is serious, they can use this as the next stepping stone to go to the next level. So that when you have people, when you're starting a new hospital, you have people from all walks of life, you're from all different organizations. Everybody says my way is better. This entry-level exercise is the basic exercise that allows your teams to come together. You can form these exercises. You can start building the culture of quality if done the right way. So you can use it to make money as well as start to sow the seeds of the culture of quality. You need that. So it's like preparing that ground, that like before winters, like on your flower bed, you do all the gudai and you put the, all the fertilizer and everything before you sow the seeds. NABH accreditation entry level is something like that. You're just preparing the grounds. Okay, if you prepare the ground well, you will have an extremely good garden, and that's your final accreditation. Now, when you say what is the level of quality these hospitals provide, the elements of patient safety, as you have built in according to the parameters that you are monitoring. Now, it will prevent a wrong patient from getting operated. It will prevent a wrong patient from getting the drug. It will, if you have, if you have gone up to the level of barcoded drug administration and all that, you probably have a, 0 to 2% medication errors. So you can really confidently say that in my hospital, I know that in my OT, these errors will not happen. You can be quite confident if you are very strict about making sure that your surgical safety checklist is filled as it is supposed to be. I will tell you where the problem happens. Once you have the accreditation done, it's a daily monitoring that is required, and that is sometimes quite painful if your data collection systems are not so good. So if your surgical safety checklist is not being filled 100% for every case in the manner that it is supposed to be filled, that means that it is filled inside the operation theater as the case is going on, not at the end of the case when everything is done. Then you just keep ticking. That also happens. So to answer your question, how sure are you of the quality that you're monitoring? So that the hospitals that have had accreditation have had a wrong limb fracture, exploration. That wrong surgeries have happened to patients in hospitals that have undergone accreditation. Why does this happen? The fatigue of data collection. You want to just slip back and say, oh, nothing happens. It doesn't matter. And suddenly you find one day you forget to ask the name of the patient, or the surgeon feels, I'm not going to do time in, time out. And lo and behold, wrong patient gets operated. It happens. So we have seen, it may happen once in a year. So the adherence to the quality standards that you will ensure in your hospital will determine how good these accreditation or how safe your patient is, because it is the rigor of data collection that determines how safe your hospital is.
Okay. I think that was a very good idea that came by from this question, that entry level is important, because people do look at it for money, but then it may not sustain a lot of the part. But like you said, I think you made a beautiful analogy in preparing the ground for sowing seeds. So the culture for quality and bringing everybody and bringing people on board. And if it's a full scale accreditation, the elements of patient safety are a lot more addressed. A lot of the statutory and other compliances do take place. So this is a very important one. Again, I think you emphasize that, it may not hold by itself, but it has to be really, culturally ingrained, and we have to be really looking at and responding. But there are chances of the fatigue of data collection which may come by, and so we may have slips. So whether full accreditation or any of the formats, ultimately it is a lot of the human factors, a lot of how quality becomes a culture and a DNA of the organization, and how internally they keep strengthening the motivation part, and keeping the teams really looking at that. But I think the moving forward, I think just to, in terms of time paucity, I would like to kind of take this point to just about a minute to kind of appreciate and kind of look at quality management from a new perspective, is what I kind of picked up. Like you said, quality management is all about monitoring and benchmarks, and it is on the data. Whether it is healthcare, it is about the data. So the data accuracy, the data fastness, the how much we take that data to analyze and respond to treatment or any safety issues is a very critical one. And I think going ahead, we will see more and more hospitals going on to a full EMR and a very integrated system, across from the aspect of hospital administration aspect, as well as on the clinical data aspect. So, and I think that would be major takeaway. The other one, of course, is from the human factors. I think looking at the human factors in terms of patient safety, team and human performance, and I think the no-do gap, I think is a very, very important one. And of course, the all-time this one that we would ultimately want is about the patient advocate. I think, I mean, I can't emphasize enough, or I'm sure for all the people who take away message would be the patient, advocate, being patient part of that. And I think on that, I really like the idea of the book. I'm sure many would pick it up. I'm the first one to pick up the book and go through that. The patient will see you now. The future of medicine is in your hands. So that would be the ultimate. And not to kind of make the the structure, but I think that's the superstructure. I think that's how I'm kind of looking at this, and really looking at the innovations in the digital one. And it is here to happen, and it is already happening in various arena, and there is a lot more things that are going to happen in the futuristic. I just kind of read today that Kidwai Hospital in Bangalore are training people on robotic surgery for all the oncosurgeons and the PG and other residents and surgeons So they are kind of creating an awareness. So already the movement on digital health and various implementation or various products and aspects is already, like, people are starting to prepare. And I think what is that is going to do to quality. One answer that we had was in the case 3, in terms of where there is all these data is integrated, and which helps us to kind of look at accuracy, and then definitely reduce the timelines for responding, and also, like, avoiding the delays that would happen. So all the aspects of quality that would go now is based on data. And of course, in terms of the building of the the teams and empowering and maybe making the people in the health system more and more getting into more of human factors. And so I like the idea that coming from a doctor at the helm of affairs, to rightly to the patient and the power to the patient. So I think that would be the way forward, and with technology, of course. And I think there are some more questions, and we will continue to talk about that. If you want to have kind of a quick final word, and then we would conclude the session.
Yeah, no, it's exciting. I'm happy that even on the day of Holi, there are like so many people, and
yes.
And thank you for participating so actively. In the online thing, sometimes you're worried that maybe people will not raise hands and ask questions. I'm very happy that you did. It actually, brings us all on the same page, because they are all learners. Okay.
Yes.
And there was a question about how, with so much of diversity, cultural diversity, and in our country, how is it that all this will be standardized? You must understand that standardization does not mean one size fits all. Standardization also means personalization. So to give you just one small example, which, data confidentiality. Now we've all seen in our OPDs, when the patient comes, let's say there's a lady who's got a breast lump. She's not even bother to walk behind the curtain. They will be like just opening her blouse and say, okay, Dr. Saab, yahan pe mere ko gaant hai. There'll be other patients. There might be her family, her relatives. There'll be just so many people. Similarly, in the telemedicine consult that happens, in the villages, there is an RMP or a kiosk, because the patients don't have smartphones and they don't know how to use this. So they usually have a kiosk, and at the kiosk, people will be, all the patients will be there. That's the Indian context of privacy. The whole family, your neighborhood, your village, depending on how socially popular you are in your own circle, everybody knows everything about you. Whereas if you are in the West, your right hand doesn't know what the left hand is doing. Right? So you have the data privacy norms and the patient confidentiality norms there, saying that without the patient's signature, it cannot be shared with her husband. And hamare yahan to patient doesn't know what she has to share. And she cannot take a decision unless she has discussed with her mother, mother-in-law, husband, children, sisters, everything. So you have to look at it in a cultural context. So we should not just go and copy paste everything that's happening. I always feel that these are things which have a cultural context, and we must not forget our context when we do these things. It's in our hands to make sure that these laws, when we make, they provide for some of this diversity that we have, because this is, who says that if I decide to share, if I have my friend with me and I want my friend to be present during my examination, who says I can't? Right? I think that opportunity we should allow, because that culturally is the sense of confidence that we get. We have a great sense of confidence in our joint families and in our, extended families, and everybody knowing what is wrong with us. So that's one. So in any case, like, these are some of the things that we cannot just say that what is good for somebody in Europe is good for somebody in India, or for that matter, in China. They have even more complex cultural situations compared to India. I mean, the whole Southeast Asia is a cultural conundrum. in that sense. Okay.
Yes.
Yeah.
Yeah. And also it could be, just to put that again, if you have let us say a medical tourism unit on, the privacy would be different than maybe when you're working. Yeah.
Exactly.
So definitely, I'm sure. So, we should be really looking at that. Just very quickly, Dr. Deepa, I think we would like, a lot of people are still staying on a little beyond the time. Can we have a group photo maybe? We would like to at least,
just switch on the screens, right?
Yes, yes.
Yes. Yes,
So,
and
yeah.
thank you very much, ma'am. It was really wonderful session. I remember troubling you when you're boarding a flight and asking you for so many things for the webinar, and all worked. So,
Where was that now?
Ma'am, you sent me the signature when you on the flight, no, ma'am.
Oh, yes.
Okay, requesting
So
all
you know what I did? I just signed on a piece of paper and I took a picture and sent you on a tissue paper. Yes.
Yeah, requesting everyone who are the participants to enable their videos so that we can all take a group shot. And I would request my IT team to support me in that.
Yes, ma'am.
Yeah. Can we put in the gallery view? Yes. And yes, please enable your video so that we can capture this moment and this masterclass.
Yeah. And I think, Dr. Uma, I think, one at the, I'm still going back to the title of structure and superstructure. And I think deep down somewhere, I kind of, I'm very happy that we had a different format to really speak and then connecting it to many, many dots. Say, for example, I think what impressed me was looking at the whole aspect of the health system itself and the ecosystem for quality. Because if we don't have early detection or at a primary center, a lot of the patients come to the hospital or, have to at a later stage in their disease.
Right.
And, that would also mean, when we deliver this, when the survival maybe or the treatment effectiveness are all going to be, impacting maybe the hospital. So I think I kind of picked it up from, many, many levels. And
yeah, there's also another, fallout of this, what will happen. Right now, when let's say I go to the hospital and I pay for something, if I'm getting an appendectomy done, I pay for appendectomy. Eventually, I should get paid for how well my patient is done, right? If the patient dies after appendectomy versus the patient has a morbidity after that, patient got infected and had a lot of complications, stayed long, or patient went home the second day, right?
Right.
If you need to do that, so now what will that do? That will force all the people in the clinical team to continue to study, so all your CME and all will become real, right? People will go and people will upgrade their skills. There'll be a good peer review. Patients will be able to choose based on the results of the doctor, and the doctor will be when they know that there is a monetary incentive. If I do better, I get paid better, right? Abhi to kya hai, jo bhi karo utna hi paisa milega. How does it matter, right? So there are a lot of positive things that will happen with this whole standardization piece that we are talking about, and this whole digitization piece that will happen. It may take a longer time, but eventually that is where we will reach.
Yes. Yeah, I think it was wonderful. And I thank you all for your smiles and picture. I hope, Dr. Deepa, you got everybody as many as possible.
Yes, ma'am. We got as many as possible smiling faces. Thank you, participants. Thank you, Uma ma'am, and thank you, Usha ma'am.
Thank you.
And happy Holi to all. And thank you. Keep tuned to IIHMR Bangalore. We'll come up with such masterclasses to you. And thank you so much.
Thank you so much. Bye-bye. Bye, everyone. Bye.
Yeah, bye-bye. Bye-bye, everyone.
Thank you. Thank you.